Welcome to session 4, which is called Precision and Durability in PVI using a Circular PFA system. For this session, we have a case presentation of a recording my team made at our hospital at St. Bernard's Medical Center in Arkansas. First, let's meet our panel. We welcome back Usman Siddiqui, Nitesh Sood, and Melanie Gunawardene. And I'll get to the case in just a second, as soon as I have my slides. Can I please have my slides? Thank you very much. So for this session, we'll actually focus on the Circular PFA system, which is the Pulse Select system. In here are my disclosures. So just as an introduction to the Pulse Select catheter, this is a circular catheter that has 9 fixed electrodes, each of which can sense, ablate, and pace. And it has a bipolar biphasic waveform and an over-the-wire design, a 25 millimeter loop, and it goes through a 10 French steerable sheath. Now, when you look at, we've talked through different PFA technologies through the day, and we've all kind of come to the understanding that proximity and contact matter, and the direct electrode tissue contact of the PFA system makes a difference in how lesions evolve. And we don't quite think that there is a reason to have increased contact force, but we need to for sure have good contact to make that lesion count. Now, the Medtronic team, I would say, has had tons of years of preclinical research on this catheter, where they're looking at thermal effects or hemolysis, microbubbles, and it has been looked at very systematically, and the catheter in its current configuration has shown excellent safety data. Now, that was also demonstrated in the PulseAF IDE trial, which was the trial that looked at this system in a global multi-center study within 300 patients, half and half paroxysmal and persistent. And what stood out is the safety outcomes, with an event rate of 0.7%, has one of the lowest safety event rates in a PFA IDE trial, and without compromising any efficacy outcomes. You can see in the paroxysmal population about 80% and persistent about 81%. Now, what I would like to show today is how I use this catheter with what I call a zero exchange workflow, without the use of any fluoroscopy or lead, but combining 3D mapping and ICE to visualize the catheter and still be able to do a PVI and deliver durable lesions. Now, the way I integrate mapping system into this catheter is, one of the special things about this catheter is the catheter, as I said, is a circular catheter, and that 5th electrode has a 20-degree tilt. So when it's tilted anteriorly, that is usually the point of maximum contact in my mind. So I tag my 5th electrode on the mapping system that I'm using. Usually it's the N-side system, because it's an open architecture system and it prevents the need for any additional mapping catheters. What you're seeing here is I'm rotating the catheter in a circumferential fashion to get adequate overlap. So here I did ostial lesions, and then I'll move on to the antrum and again deliver those antral lesions. So again, making sure that I have adequate overlap with my 5th electrode, and that kind of guarantees me that I have contact. So now let me take you through this case. So here we are getting access with ultrasound, which is standard for me. And you can see we're pre-closing. That is also standard of practice for us. Now with this, with this paroxysmal AF patient where I'm just doing PVI, I usually send them home the same day. It's just 2-axis, no CS. You can see I'm visualizing the SVC on ICE. We're dragging down with the FlexCath sheath. And it's a very nice sheath that has great one-to-one torque transmission. I use an RF wire through that sheath. Usually I try to do my transeptal kind of in an anterior mid approach or an anterior inferior approach. And I like to take my ICE catheter into the left atrium. And what you're seeing here is the ICE kind of sliding into the left atrium through that same transeptal puncture. Once we are across, I'll take the sheath back in, and now we're ready to come in with the catheter. So the first thing I do is I go into the vein with the wire, and we actually, if you look in the mapping system, which is on the top left, you can see we have kind of tagged the wire in, and we've got calipers that are on the wire, and the wire shows us as that gray dot. And here I'm bringing in that pulse-select catheter into the left superior pulmonary vein. You can see I have selected my fifth electrode, is the one that they're highlighting. Like every PFA catheter, you'll see acute, actually termination of the electrograms. And that really doesn't matter. To me, that's one of the reasons why I like using ICE and mapping. And to me, mapping gives me so much confidence in that I have overlap, especially when I have no electrograms to kind of chase. So here you can see as I'm rotating, I'm looking on ICE to make sure I have contact. But when you're in the ostium, here I'm delivering osteal lesions, and I counterclock the catheter over the wire. So it's kind of like the old lasso that we used to have. Just torque it in, get it inside the vein. And you can see on the ICE, which is on the top right, that catheter is deep within the vein. Now, sometimes if the electrodes are too close to each other, I'll have to maybe open it up a little bit or move it around a little bit. And I keep an eye on the wire and make sure the wire is further away from the catheter, stuff of that. So usually about 4 lesions in the ostial plane. And what I'm doing there is a projection overlay map on the inside system that gives me an idea of where that lesion might have gone on. Now, I welcome the panel to join along as well as I take you through this case, and feel free to interrupt me if you have questions or have another workflow.
Really?
So here I'm actually bringing the catheter back into the antral location there. You can see on ICE, the catheter is sitting at antral location. We're tagging. I use green dots for my antral lesions and yellow dots for my osteal lesions, so I can kind of keep an eye on it. So here you can see I'm kind of rotating. Usually about 6 to 8 lesions. If I can have the panel back as well. I'm curious to hear what the panel, what their workflow is and how many lesions they do per vein. Nitesh, you have had a lot of experience with this catheter.
Can I ask you a question? How do you decide on your
Yeah.
first application inside the vein? Do you look for the most distal electrogram, or is it like you look on ICE where you want to start? How do you choose where you're beginning?
Oh, that's a great question. So I usually take the catheter. Remember, this is not a high density catheter, but I'll actually take it in a circular fashion and kind of take the vein and kind of map the vein and see how long my pulmonary vein sleeve is. And usually I try to get that whole sleeve. So wherever my distal signals is, I'll start there and kind of pull back. And this catheter, you really don't need 4 lesions inside the vein. So I kind of, if it's a short sleeve, I'll just do it in one plane. But if it's a long sleeve, I'll actually do it in a I would say more 360 kind of 3-dimensional plane. Usman and Nitesh, like how do you guys
I agree.
do your osteo?
So I think that's a very good advantage of this catheter. You can really get this to do the pulmonary sleeve nicely. Sometimes, as you're showing here, it's the vein is reasonably good size, but you can get both the inferior veins. You can have some back pressure from the wire as you're trying to push the catheter in, like any large footprint catheter. So in those situations, I agree, Devi. I do the same thing, but one of the things you can do is if you are really opposed against the ostium, like you are there, and if you're trying to get this to get smaller and get into the vein, you can actually use a knob on the. I think I see you doing that, so you have all the tricks of the trade. But you can use that knob on the sheath on the catheter, which is meant for actually deflecting the catheter. But when you're in contact with the tissue, it makes that circle a little bit smaller, and it gets you just inside the ostium and gets very nice tight osteal lesions. The other place I think this really is good is in smaller atriums. You can keep the lesions very, very tight, very, very osteal, which prevents you from having to do unnecessary posterior wall ablation, in young patients where you're doing PVIs.
So yeah, I
I
completely
agree.
agree. I think there are 3 things which stand out in your presentation of these cases. Is number one, that the amount of microbubbles, as you can see with the system, are minimum with these applications. I wanted to point that out. 2,
Usman,
the
can I
sheath.
interrupt you 1 second? can I interrupt you 1 second? I just want to kind of show the right superior pulmonary vein. We're in the right superior pulmonary vein, and the way we know we're in the right superior pulmonary vein is because you can see the PA on the ice. So one of the things that we do on ice, we're not doing pre-imaging in any of these patients. So we're looking on ice to make sure we address all the venous anatomies. So, and you can see we're kind of deep in the vein there. Go ahead, Usman. Sorry.
Yeah, so that's one thing which really stands out. Second, the use of sheath to get the stability. So even though electrode 5 is the one which is pushing and you're using wire as a cushion to get contact, but you're working against a moving heart. So I love it that you have the sheath almost close to the tip. So you can even let go of your hands. And this sheath is actually really, really good to maintain stability during that lesion. Number 3, you talked about electrograms. These electrograms are actually a little bit different because this true bipole is almost pretty equal to some of the bipoles that were used on a standard, ablation catheter. So if you have contact in some area and you give energy in that area, that electrogram may go away. But a lot of times you will continue to see electrograms in other area where you didn't have contact. So I would say the electrogram identification by these poles is much more reliable than any of the other systems, single shot systems, which are available at this time, just because of the bipole. So there are a lot of things to help EPs in this. Yeah.
Yeah. So here I'm actually going into the SVC, which is something I actually do for most of my paroxysmal cases. I'll actually go and map the SVC, and you can see my catheter is at the level of the PA in its short axis. So that's where I like to see if there is any signals. And if the SVC is active, especially in a female patient, I actually do SVC isolation on a routine basis. And we actually do it treated like an osteal lesion, just 4 lesions around. And in the thermal energy phase, I never did it as much, but now with the PF energy, I feel very comfortable. And like Nitesh said, we can keep those lesions very tight, so we don't end up with a critical isthmus in the posterior wall, like this map is showing. And you can see I actually did a HD grid map because it was a recorded case, and I wanted to kind of show you the difference in here. And you can clearly see like it's nice and tight. I keep my projection mapping like tags very tight as well, so in that way I'm not having a big spread of lesions. And we kind of worked on this quite a bit. And I know, Nitesh, you have a workflow as well, if you want to just jump in.
Yeah, we same thing. We use a lot of 3D mapping for this, and Devi, that map you showed, I can assure you that right now this is other than maybe a focal catheter, you could never get such good osteal lesions without having to take out the posterior wall of the roof, and leave an isthmus. We use contact mapping, so we drop it down to about 2 millimeters on the pre-map. So the inner projection, so that when you have within 2 millimeters internal projection on the pulse field catheter, because this is an impedance-based system, it really is good. This one allows you to do it because, unlike some others, EnSight will show you all the different poles. In a lot of the other ones, it's more of a sort of we take one pole and interpolate the data for the other poles. But here you can see all the electrodes in real time. So I think this makes a huge difference along with ICE 3D mapping.
Can I?
Yeah, I think one of the things. Yeah, go ahead, Melanie.
Sorry.
Yeah.
Sorry. So first of all, to your SVC ablation, I really enjoyed how you showed this on ice. And there's actually 2 publications. They're both still with the pentaspline, but one was a European study where they could see some sinus node dysfunction, and the other one was a US study with ice where they said they never saw sinus node dysfunction because they could always clearly say that anatomically they were at the junction. Because you could potentially also map the activation, right, and exactly know where the sinus node is, but I saw you only did an anatomical map and you looked into ice. So do you feel like ice is giving you enough confidence to know that you're not going to harm the sinus node, especially when what Nitesh also just said with the small lesions or smaller lesions that we create because the footprint of the catheter is smaller?
Yeah, I have to say that, we've done probably over 1,000 cases in the SVC and have not had any sinus node dysfunction issues, as long as I stay at the level of the PA. Now, I never come below that level because then you start encroaching into the base of the appendage. And as long as I have signals in that location, I will. I'm curious to hear if any of the others actually do SVC.
Yeah, I do it. So I do SVC in every paroxysmal case. But I will use your PA trick next time. I don't use that. What I do is this: to avoid the sinus node, I go up in the SVC and I find where the vein potentials are septally. Most of them are pretty high up. They are truly across the right upper. So when you see those nice vein potentials delayed, I do just atrial pacing from the RA. You can see a nice delayed SVC vein potentials towards the septal side. And that's the level I do it at, which is typically about 1.5 centimeters above the SVC RA junction. And I take out those potentials. And that's my marker of staying away from the sinus node.
Same.
I have to say, yeah, I was going to say that, of course, I didn't use fluoroscopy, but this is definitely a system that can be used with fluoro. And Mel, you have a lot of experience of using the system with fluoroscopy. Not everybody feels comfortable, putting the ice into the left atrium and such. And do you want to comment a little bit on how you are using this catheter with fluoroscopy and how you assess contact on fluoroscopy?
Yes, absolutely. So I think that when you only have fluoroscopy, you do need to know where the veins are, right? So you would need at least some angiograms to guide you so that you know where the level is. Otherwise, it's hard to have any guidance. The good thing about this catheter, it is very smooth for you to maneuver, right? And it's very easy to maneuver it around the vein. However, saying that, it means that it also kind of falls always into the same place when you're using a fluoro-only approach. So you have to really make sure you keep rotating it, maybe use two angulations like LAO, RIO, making sure that you are on the anterior and posterior aspect and superior and inferior. I always do an extra deflection of the sheet to not miss the carina, because I do think that the catheter is sometimes smaller than the actual vein, and then you would miss it without the 3D map.
Yeah. Can the team actually get my slides back? I want to just see if I can show some of the durability data that we have on this system. Can we go back on the slides, please? If you don't mind. Actually, yeah, so we actually did, because we were doing zero fluoroscopy workflow, we actually did invasive remapping in a set of our patients. And what we saw was, so this was our cohort. We had 25 paroxysmal and persistent patients that we brought back about 6 to 8 weeks after they had their initial procedure. Now, these were not patients that we planned on invasive remapping. So these were patients that actually showed up for LAO occlusion. So very unbiased population is what I'd say. These were all comers. Anybody that had PFA, we were remapping at that time. So we had a protocol in place. So it could have been any catheter for that matter. And the investigator that was mapping was blinded to which catheter was used for the PFA. So we had a pretty strict protocol. And what you'll see is, of course, the one thing that stands out is the CHA2DS2-VASc scores are pretty high because this was an LAC population. And what you see here is, for this particular cohort, you can see the procedural characteristics. All of the PFA cases with the PulseSelect system that were included in this analysis were zero fluoroscopy. You can see we didn't have any procedure-related complications. You can see the dwell times. And they were pretty efficient procedures. We did use general anesthesia in almost all of our cases except for one. And all of our patients actually went home the same day. But what stands out is the durability. And this was, as I said, about 60 days remapping, and you can see the per vein durability was pretty high. With of course acute isolation was 100%, but 98% per vein durability and 96% per patient durability. And you can see the different veins and the different regions, and the SVC was isolated in all the patients. We had clinical recurrence in 2 patients, but they had durably isolated pulmonary veins. So obviously not PV triggers. And the 2 patients that actually had reconnection did not have any clinical recurrence during the short follow-up phase. And these were some of the representative maps. So this is the future. And I want to just kind of put that plug in there. This is the future of potentially integrating. Of course, this is not available, not approved in the US yet, but integrating this system into the FARA mapping system where you could actually visualize this catheter within the FARA system and do kind of a map and ablate strategy for physicians that actually have the FARA system in their lab. And that's also something, having the versatility of the tool set, right? We're having a focal medium footprint tool that has dual energy and having a fixed electrode configuration that allows for PVI workflow, I think is a nice versatile approach. And I want to give it back to the panel to just maybe give their final thoughts on where they see how these different platforms now play a role. Mel, I'll start with you. Like, how do you choose what catheter do you pick for what patient?
Yeah, that's a really good question. So I think because in our lab, I know you're super efficient in yours, but I would say that we also have a high turnover. So obviously, all first do procedures. We usually go for a PVI only strategy. So we use single shot devices. And that gives us the time for all the complex cases and all the redos to decide on a more sophisticated approach with the mapping system. And this is how we choose. So basically, first do single shot device, and we go from thermal to still PFA, which is also a question of reimbursement, to be honest, because of the costs of the catheter and everything in our country. We still mix it. We're not in a PFA only world right now in Europe.
Yeah. Nitesh, can I ask a question? I know we talked about how
Sure.
this lesion sets are very tight, right? And you almost spare the posterior wall in most cases, but sometimes you do get into an atrium where it becomes that the veins are like they are pretty north, is what I call it, and they're
Yeah.
very close to each other. How comfortable do you feel taking this catheter outside the PVs?
I do. I mean, I did that for a long time. And I feel like it's a little limited on the lower posterior wall if you're trying to use a wire-based system to do the inferior posterior wall. But for the roof area, it's very straightforward. So there have been cases, you're right. I actually choose this Pulse Select mostly for my really young patients. It's also, half the cost of the other systems that are out there. So, lab, that's something to, think about. Otherwise, I guess you could argue use a Farah for everybody or, whatever else, Farah Pulse, but I think it's half the cost. So if you're doing just a PVI in a young person with a small atrium, this is not a bad option. And it, I think, works really well for what I call the upper half of the posterior wall. So if you're looking at inferior veins up into the roof, if there's a small triangle that's left from PVI, then it's reasonably easy to do. But if you're looking for more extensive inferior posterior ablation, it's not as conducive because the atrium sort of shallows out, in the vestibular area. It's not easy to do that with a wire-based system. But otherwise, and I've done mitral lines with this as well, to be honest with you, not ideal, but it certainly can be done.
Usman, I'm going to ask you a provocative question. So you have been a focal RF person for years, and you were very skilled at it. And then you get this over-the-wire system. Can you walk us through what your learning curve was?
Yeah, it's great. First, before that, I think we need to understand the value the system offers. This is the only system available for PFA, which is working at 1500 volts. And the way they've been able to do this is because of the biphasic waveform and of the waveform, which is really double. You're getting from one electrode to the other, odds and even together. And with that, you're getting the depth you want. So that's what you're seeing in your cases as well. Why are you seeing less microbubbles? Why are you seeing such demarcated lesions? It's because the amount of voltage that you're using is very minimum compared to any other system out there. But of course, you put that together with your recurrence data and the remap data. If it's able to perform that, I think a system like this will continue to have value. So from my standpoint, so younger patients, paroxysmal AFib patients, safety is the biggest thing. You were at APHRS, and Japan has a very wide use of this catheter, and they're very meticulous about publishing, and they check the heptoglobin levels in every patient. And there are at least 3 publications from 3 different centers where consistently the hemolysis is much lower in this catheter than any other catheter in the system. So that's that. So that's one of the values. So there was a learning curve for this. This is not as simple as the pentaspline, but I think if you focus on this 5-6 electrode, as you mentioned, I think life becomes so much easier because this forward tilt, this is not a standard lasso catheter. That forward tilt is what gives you the stability, everything. So if you make sure that 5-6 is around the vein ostium, around the vein antrum, you will have really, really good durable lesions. But so on mapping system, we identify that. On ICE, we follow that. As Melanie mentioned, if you're doing fluoro, then the way to see this 5-6 is look at opposite of 1 and 9. So where your wire comes out is 1 and 9, and you follow that up. And I think for fluoro-based only, sometimes it's difficult to follow that 5 and 6. But if you do that, I think, so that's where I choose this catheter. I hope that answered your question.
Yeah, it does. And Nitesh, I want to ask you another question on something that was seen on a publication on people getting this catheter knotted up. Can you walk us through what you should not do with this catheter, especially since it's an over-the-wire catheter?
Yeah, I think there's 2 times you can get into trouble sort of doing something like that. One is if you have the, wire back and you are really sort of flinging the catheter around in the atrium. People are used to using the pentaspline without the wire for the posterior wall and roof. That's where you can get into trouble. The other thing is, which, sounds easy, but sometimes it's not done, is when you deploy the catheter, you really should be deploying it a little bit further away from the transeptal and not into the vein. That also gets the catheter sort of hung up. And the last one I would say is when you're recapturing the catheter, if you don't have the knob all the way forward, that, even if the catheter is collapsed, if the knob's not all the way forward, the tip can get bunched up. And that's the other place you can end up in trouble, and the catheter can get stuck in the sheath. So, as long as you sort of follow those basic protocols, it is typically easy. But when you're trying to maneuver the catheter, especially on the anterior portion of the right upper, and you're having a difficult time, it's better to, push the wire, take the catheter into the atrium, rotate the electrode 5, and then push forward versus pushing when you are engaged in the vein. That's when you can sort of get into trouble with knotting. At least that's been my personal experience. Haven't knotted one yet, but hopefully those things help me avoid that.
Melanie, any final thoughts on where you see how this catheter is it here to stay, or is Affera, the Sphere 9, going to take the world?
Well, that's a tough question to answer, but what I can say is what you started with, that outstanding safety profile, and just what Usman said. And I think that for all technologies to come, this is a bar that has been set, and we need to make sure that we don't accept devices and systems that show a poor profile in this regard, right? And I think that's what I would finish up with.
And Devi, another point I think which wasn't worth mentioning is sedation. There's now reasonable amount of literature, both in US and both in Europe, of doing these cases with moderate sedation. And the reason you're able to do this, again, is the kind of waveform that you have and the localized application, quick application it does. So I think if we continue, as you move on to ASC setups and these outpatients, I think there's going to be a lot of value for catheters like this, doing sharp demarcated lesions, smaller sheets, less risk, early discharge, no risk of, hemolysis and whatnot. And yeah.
And again, on that one last thing, on that note, Usman, I completely agree. And the other trick that works really well is using lidocaine, 50 milligrams or so, just as you're going transeptal. And if you do that, the coughing under conscious or deep sedation is much lesser than without, because that can be a problem with 3D mapping. But that trick of using lidocaine really helps you do this under conscious sedation or deep sedation.
All right, guys. Well, we have reached the end of the session. My thanks to Usman, Nitesh, and Melanie for their great contributions and insights. Stay with us for the next session.
Thank you.
Thank you.